Welcome to the Minnesota Department of Health webinar, Knowledge is Power, Pregnancy and CMV. My name is Kate Cass, and I will be your moderator today. I want to cover some brief housekeeping before we begin. This is a re-recording of the webinar, which originally took place on April 2nd, 2025. As is often the case, and I'm sure you can all appreciate, technology is great until it isn't, and we had issues with recording. This webinar will be available on the Minnesota Department of Health Cytomegalovirus website in the For Health Professionals section. I do encourage sharing this resource with others, as the more people who know about congenital CMV, the better. This is so important because congenital CMV is the leading infectious cause of birth defects and non-congenital hearing loss in Minnesota. And studies have shown when there are more people who know about CMV in a population, there are few cases of congenital CMV. That is why we decided on the title of Knowledge is Power, because with CMV, it is the truth. Knowledge about CMV supports families and caregivers. I want to express special gratitude to our presenters today, Gina Liverseed, the Minnesota Department of Health CMV Specialist, and Jess Wright, our parent partner and an advocate who is here to share her family's experience with the congenital CMV diagnosis. At the end of the webinar, we will address some frequently asked questions about CMV and congenital CMV. And lastly, I would like to encourage everyone to register with Help Me Connect. Help Me Connect is a relatively new website that connects Minnesota families with resources and services in their communities. Last year, there were over 600,000 unique visits to the Help Me Connect website, and doulas and birth workers were in the top 10 Help Me Connect searches. Finally, before I hand the presentation over to Gina, I would like to thank you for supporting birthing parents and families. We have long known that doulas and birth workers provide positive experiences to those who give birth. In fact, many anthropologists consider birth workers as the actual oldest profession. As long as people have been giving birth, they have needed support. You provide connection, education, empowerment, security, safety, and comfort. In Minnesota, data shows that those that have doulas have better birth outcomes through lowering rates of low birth weight, premature birth, labor times, cesarean section, and need for medication. I'm amazed and humbled by your accomplishments and your dedication. And as educators, you are essential health messengers. You know these families, you know their dynamics, and I can't imagine a better partner for providing knowledge and spreading the word about congenital CMV than you. So with that, I will introduce Gina. Gina Liverseed is a CMV Nurse Specialist in the Children and Youth with Special Health Needs section at the Minnesota Department of Health. In this role, she is responsible for coordinating longitudinal follow-up of children identified with congenital CMV and providing education about CMV to public and private provider audiences. She holds Bachelor and Master of Nursing degrees from the University of Minnesota and a Doctor of Nursing Practice degree from the University of North Dakota. Gina has over 20 years of experience working as a maternal child health nurse and a women's health nurse practitioner.
Well, thanks, Kate, for that introduction, and thank you to everyone who is taking time out of their day to watch this webinar today. So after this webinar, you should be able to describe the basics of CMV and congenital CMV, which we'll call CCMV, describe the ways to reduce risk of CMV infection during the preconception time and during pregnancy. We'll hear from Jess to help us understand the impact of CCMV on children and their families. And by the end, we hope that you'll be able to locate CMV and CCMV resources that you'll be able to use to help inform and support pregnant people and parenting families. So we will go ahead and get started. And we'll be starting with the basics of CMV. So CMV stands for Cytomegalovirus. This is a common virus that's actually a member of the herpes virus family. So similar to other viruses in that family, this is a virus that stays in the body for life after an infection and can periodically reactivate. There are multiple strains of CMV, meaning that there's a potential for reinfection. So people can get CMV more than once in their lifetime. And I think it's important to mention that this is not a new virus. This virus has actually been observed first in the lab way back as far as the 1800s, and it was first isolated in humans in the 1950s. And it's been since then that we've known that CMV can impact people during pregnancy. CMV is a common virus. In the United States, nearly a third of children are infected with CMV by age 5, and somewhere between 50 to 90% of adults are infected by age 40. The number of people in the population, which we call seroprevalence, with CMV can differ based on race, socioeconomic status, and where they live. And we know that people of color, those of lower socioeconomic status, and those living in urban areas tend to be more likely to test positive for CMV. In developing countries, the adult seroprevalence rate is almost 100%. So CMV is commonly transmitted through contact with bodily fluids that contain the virus. And as you can see from the list here, the virus can be in many of our bodily fluids. One of the most common ways that CMV is spread is through the direct contact with urine or saliva of young children. And this is because children typically shed the virus or have virus present in those body fluids for a longer amount of time than adults. And typically the amount of virus in their bodily fluids are higher. So one of the most common ways that it spreads is through close contact in households and in childcare settings. And so we know that people who work closely with young children or have young children in their home are at greater risk of getting a CMV infection. So we use this photo kind of on the right-hand side of the screen to show how this mom might be getting a CMV infection from her toddler by giving a kiss on the face very close to this toddler's mouth where there might be some saliva that could contain CMV. Most healthy people don't know that they've had a CMV infection. The virus typically doesn't cause any symptoms. When they happen, it might seem like just a cold or a flu with maybe a sore throat or a fever or fatigue. And really, CMV infections for healthy adults typically are harmless. When they become important is for people with compromised immune systems and during pregnancy. And during pregnancy is when it can impact a growing fetus. And so now we're going to switch and talk to the basics of congenital CMV. So pregnant people who develop an active CMV infection can unknowingly pass the virus to their growing fetus. So you can see in this picture, now the virus is going from that pregnant mother to their fetus. And that occurs in about 3 to 6 infants per 1,000 births each year in the United States, so impacting over 30,000 infants per year. Studies of the CMV prevalence have identified disparities in congenital CMV among communities in the United States, with the highest prevalence happening in African American and multiracial infants, and the lowest prevalence of congenital CMV among non-Hispanic, white, and Asian infants. And we're going to talk about some of those disparities in our own state a little bit further along in the presentation. So what happens after an infection with congenital CMV? We know that congenital CMV can follow a maternal primary infection, a reinfection, or a reactivation. So a primary infection is when someone gets the infection for the very first time in their life. A reinfection is what we talked about before, where another strain can cause an infection. And a reactivation is when someone's had a previous infection and it has previously been dormant in the body and not causing symptoms, or the person has not been shedding it, and that reactivates. We think that about 2/3 of congenital CMV infections are caused by reactivation or reinfection. However, we know that the risk to the fetus is highest following a primary infection, so a person getting it for the very first time just before they get pregnant or in the first trimester. When a pregnant person gets a CMV infection, there are several ways that it can cause injury to the growing fetus. The first way is through injuring the placenta. It actually causes the placenta not to function as well. This causes the fetus to be not get as many nutrients or blood flow as it should, and can cause some end organ damage, and also causes the baby to be at risk for an intrauterine growth restriction or being born small for their gestational age. The virus can also transmit to the fetus and start to replicate directly in the fetal cells. This causes disrupted development of those cells. So cells in the brain don't form quite as they should. And this can also happen to cells in the inner ear, which is why one of the most common impacts of congenital CMV is hearing loss. And then the last way that is thought to cause injury to the growing fetus is through the maternal immune response. And so if this is an infection that the mother has had before, or even not had before, they start to produce immune cells to fight the infection, and this can cause an inflammatory environment that causes injury to the fetal cells in utero. So when babies are born with congenital CMV, each baby is impacted differently. No baby kind of presents in the same way. Most of the time, we do classify babies as either asymptomatic, or some people say clinically inapparent, or symptomatic. And so most kids are going to be asymptomatic, so they won't have any visible signs at birth. They may still be identified with hearing loss at birth or later in childhood, but most babies who are born asymptomatic will go on to have typical development. About 10% of babies are born symptomatic, which means they have one or more visible signs at birth. They might have a small head size. They can be born with a rash called petechiae. It's little pinpoint, kind of reddish or bluish dots on their skin. They can experience significant jaundice or yellowing of their skin, and they can be found to have an enlarged liver or spleen from the virus impacting those internal organs. They might show some laboratory abnormalities like elevated liver function tests or low platelets. They can have findings on imaging taken of their brain, so intracranial findings that show some of those impacts of the virus on their brain development. They can also exhibit chorioretinitis. This is an inflammation of the retina on the innermost part of their eye. And we know that babies who are born with any of these visible symptoms or findings tend to have more long-term health challenges than babies that are born asymptomatic. And so there are possible long-term impacts of congenital CMV as well, and they really can exhibit across what we like to just call a spectrum. And so to the left-hand side of the spectrum are babies who are born symptomatic, again, are more likely to have more long-term health concerns. So in the most severe cases, congenital CMV can cause miscarriage, stillbirth, or infant or child loss. They can be medically complex, have multiple impairments due to their infections. Towards the right-hand side of the spectrum, we have babies who are born asymptomatic, and as we talked about, they're more likely to have fewer delays or impairments from their infection. They can still experience a hearing loss, again, either at birth or sometime in childhood. And then in the center, we have some developmental delays. And this is an area that there is still active research going on. Some early research is showing babies born with congenital CMV are at a higher risk for autism and some other learning challenges. And so again, kind of just exhibiting different symptoms over a spectrum. So regardless of where babies fall on kind of that spectrum of effectiveness, there are treatments that are available. So antiviral medication can be given for babies who are to the left side of that spectrum and are classified as moderately or severely impacted. That medication has to be started within the first 13 weeks of life. So that's why it's important to be identifying these children early. All babies qualify in our state for early intervention services, which is monitoring and interventions to help babies make sure that they're growing and developing as they should based on their age. We also know that managing existing signs of congenital CMV is important. It's important for families to monitor for new signs, such as hearing loss. And because the diagnosis of congenital CMV can cause a lot of anxiety for families because of the uncertainties, along with the diagnosis, family support is an important treatment for all children with congenital CMV. So in order to be able to get families connected with resources and support and treatments, we need to know that they have congenital CMV. So we are going to talk a little bit about how families find out that their child has congenital CMV. So there are some ways for people to find out during their pregnancy. In the United States, however, there is no recommendation for routine prenatal blood testing. In some cases, people do receive a test. Oftentimes, it follows a sign or a symptom in the mother that prompts a provider to order a test. In mothers, it is done by blood, and it has to have some follow-up testing because it's what we call an antibody test. And so the lab result that you get back has to differentiate between a current infection and a past infection, because people will show some immunity or antibodies to CMV during their lifetime after a primary infection. And I think it's important to note that even if someone does end up having a test and it shows that they're testing positive for a current infection of CMV, a maternal infection doesn't always result in a fetal infection. It kind of depends if it's a first infection or a past infection and when during pregnancy that infection was acquired. Sometimes there can be signs of congenital CMV found on a fetal ultrasound. In those cases, a pregnant person will often be offered an amniocentesis to check fetal amniotic fluid for CMV, and that's typically done in collaboration with a maternal fetal medicine specialist. And it's important to note that right now, if someone is diagnosed with CMV during pregnancy, there are no FDA-approved treatments. There is Valtrex or valacyclovir being studied in research settings, but right now it does not have routine approval. So someone who does get that diagnosis during pregnancy needs to seek out that care in specialized settings. So the more common way for a baby to receive a diagnosis of congenital CMV is after birth. And this diagnosis has to come within the first 21 days of age. And this is because CMV is so present in our environment, it's present in breast milk, that if a child tests positive for CMV after 21 days of age, it's really difficult to know if that infection was acquired in utero, which makes it a congenital infection, or acquired during or after birth, which we call an acquired infection. Acquired infections in full-term healthy babies do not typically cause the same kind of long-term impacts and complications that a congenital infection can. The gold standard for detecting CMV in a newborn is by urine. Saliva is sometimes also used, but that has to be collected very carefully because CMV is present in breast milk, and babies can get a false positive result if the saliva sample is collected too soon after their last breastfeeding. Oftentimes, urine or saliva will be ordered if the baby has signs or symptoms, or in some health systems here in Minnesota, there are still protocols that require a urine or saliva to be collected from a baby if they refer on their newborn hearing screen. CMV can also be detected by newborn dried blood spots. They're slightly less sensitive, meaning their ability to detect the CMV virus in the blood spot is slightly lower than the other methods of urine or saliva. But blood is collected from infants, almost all infants in our state, within about 24 to 48 hours of birth. And these blood spots can be used to test all babies for CMV, and we call that universal screening. And really the purpose of screening all babies in this way is to identify the infection and any health or developmental outcomes as early as possible so they can be offered treatment. So in June of 2021, the legislature here in our state of Minnesota passed the Vivian Act. And this resulted from a grassroots effort of families bringing congenital CMV forward as a public health concern and asking the state to pass a law that would require more babies to be tested for congenital CMV. And this law did pass in June of 2021, and it directed the Advisory Committee on Heritable and Congenital Disorders to review congenital CMV for inclusion on the list of tests to be performed by the newborn screening program. So the committee did a review of the condition and recommended CCMV to be added to the panel in January of 2022. And so that recommendation was approved by our Commissioner of Health, and it took the Department of Health about a year to get ready to add that panel. And so in February of 2023, Minnesota became the first state in the US to screen every newborn for CCMV. The other part, the directive that came out of our VIVINAC legislation was it also directed the Commissioner of Health to ensure education and outreach about congenital CMV. So that is something that the Department of Health is working on as well. So all babies in Minnesota are now all tested for congenital CMV. And so they have their dried blood spots tested at the Minnesota Department of Health Public Health Lab for CMV, along with about 50 plus other newborn genetic and metabolic conditions. If congenital CMV is detected in the dried blood spot, the primary care provider of the infant is notified, and the primary care provider communicates with the family. The first step is typically bringing the family and the baby back in to collect a urine sample from the baby for confirmation of the infection. If the urine test is positive for CMV, there is a recommended steps to complete to help determine the severity of the disease and help the providers recommend treatment for the baby. The additional evaluations include laboratory blood testing, head imaging, which is usually a cranial ultrasound. They recommend a diagnostic audiology examination, even if the baby passed their newborn hearing screen, and a dilated eye exam by the pediatric ophthalmologist. And again, this is to look for all of those signs or symptoms of congenital CMV that kind of can be under the surface and not seen on just a routine physical exam. These evaluations are usually coordinated by the primary care provider, and if any signs or symptoms show up on any of these exams, the baby is referred to a pediatric infectious disease specialist for further evaluation. So since we've been screening for congenital CMV in Minnesota, again, that started in February of 2023, and this data goes through March 20th of 2025, 359 babies in Minnesota have been identified with congenital CMV. So we average about 16 babies a month, and this comes out to 1 out of every 350 babies born to Minnesota families in our state. About 57% of all families with a baby identified with congenital CMV lived in the 7-county metro area at the time of birth. And this isn't surprising because about 60% of all of our births in our state happen in the 7-county metro. CCMV is widespread in our state, though, with 55 of 87 of our counties having had at least one resident child born with congenital CMV. In our state, similar to the prevalence in the research, our highest prevalence is in our Somali families, with 8 out of 1,000 Somali babies born to Somali mothers, and Black African American mothers, with 6.1 out of every 1,000 births to that group testing positive for congenital CMV. The lowest prevalence is in white, not Hispanic mothers and our Asian mothers in our state. And just a note of caution with our asterisk that in some of these groups, the birth numbers have been small. So we're still kind of interpreting these numbers with some caution, and we'll be looking for trends as our numbers increase. So a special note about hearing status and congenital CMV. So as I mentioned earlier, hearing loss is the most common long-term impact of congenital CMV, with some studies showing up to 20 to 25% of all babies eventually developing some degree of hearing loss. Hearing loss related to congenital CMV can impact one or both ears and be present at birth or have a delayed onset. So far, out of the babies born in Minnesota with congenital CMV, 22 children have also been identified with hearing loss. And so it's just really important to know that all children with congenital CMV, whether they showed symptoms at birth or were asymptomatic, all of them should have hearing monitoring at regular intervals throughout childhood so that any change to their hearing can be found as early as possible. And now I am very happy and honored to turn the presentation over to Jess Wright. Jess and I have known each other for a couple of years. She was one of the first moms I met when I came into the congenital CMV world, and she has just been such a great partner and an advocate for congenital CMV in our state. And I'm just so happy that she can be here with us today and to share her story about Jackson.
Thank you. So my name is Jess, as Gina said. I'm the proud mom of two incredible boys, Colton, who is almost 6 next month, and Jackson, who will be 4 in July. Today, I want to share our family's journey with congenital CMV or CCMV, a condition I had never truly heard of until it became a part of our lives. My hope is that by sharing our story, I can help spread awareness about this common yet rarely discussed virus and highlight the importance of educating parents. When I was pregnant with Jackson, I had only heard of CCMV once before. My older son, Colton, actually failed his newborn hearing screening in the hospital. As part of that follow-up, right after birth, he was tested for CCMV with a urine sample, but his results were negative. He was ultimately diagnosed with diagnosed with unilateral auditory neuropathy spectrum disorder, which resulted in profound hearing loss in his right ear. I assumed CCMV was something we no longer needed to worry about, and I really didn't need to with him. Little did I know that it would become a part of our life with our second child. My pregnancy with Jackson was fairly uneventful. Though looking back, I had a sinus infection in February, and I later caught a stomach bug that sent me to the ER for fluids and dehydration. It turns out that one of those seemingly minor illnesses, the sinus infection, was likely when I contracted congenital CMV, around 17 weeks gestation. Jackson was born in July of 2021 via scheduled C-section at 39 weeks. He was big and healthy, 8 pounds, 7 ounces, 21.5 inches long. He did have a port wine stain birthmark on his face, which did prompt some additional appointments, but we were reassured it was really nothing to worry about. When he passed his newborn hearing screening, I breathed a sigh of relief, thinking we had avoided the audiology concerns that we faced with Colton. Well, during our hospital stay, a research student asked if we'd participate in a CCMV study. Since it only required a cheek swab and testing Jackson's newborn blood spot card, we agreed without hesitation. I do want to note that now all babies in Minnesota are tested for CCMV through the newborn blood spot card, but this would be a similar time frame to finding out via MDH as it was finding out from this research swab. I barely gave it another thought until 2 weeks later when our pediatrician called us on a Saturday morning. She informed us that Jackson had tested positive for CCMV. This news was a gut punch. I felt an overwhelming wave of sadness, fear, and guilt. I started Googling everything I could about CCMV, learning that it's a common virus that can cause permanent, life-altering conditions in babies when contracted during pregnancy. The hardest part was realizing how preventable exposure can be. Simple precautions like avoiding sharing food, drinks, utensils, pacifiers when you stick it in your mouth with your toddler could have reduced my risk. And yet no provider had ever mentioned CCMV during my prenatal care. I had both boys through the same clinic where I saw numerous OBs and midwives throughout both of my pregnancies. I was told to avoid deli meat and to be careful when changing my cat's litter box. But not once did anyone mention the risks of CCMV, despite how easily it spreads among toddlers. When I went back for my 6 weeks post C-section visit, my doctor said she read the notes and, I quote, Jackson didn't look like a CMV baby. I'll just say it didn't bother me then, but it has now because it just goes to show how little OBs were talking about CCMV or knew about it. We were quickly connected with Dr. Schleiss, who's an infectious disease doctor at the University of Minnesota. He guided us through the next steps. Jackson underwent blood work and a brain ultrasound, an ABR hearing test, and an ophthalmology exam. His ABR was clear, and he showed no signs of vision issues as well. However, his blood work confirmed a high virus count, and his brain ultrasound revealed tiny cysts and calcifications. Mild findings, but still concerning given that positive CCMV test. Because Jackson was considered on the borderline of symptomatic and asymptomatic, we were offered an antiviral treatment called Valcyte. Through that came potential side effects, and we ended up deciding that the benefits outweighed the risks. Choosing the treatment meant weekly lab visits for 6 months, which was tough on Jackson and on us. The drug itself was hard on his little body, and keeping him healthy with a weakened immune system during some COVID outbreaks was a constant challenge. The weekly lab visits were no small feat. We had to find the right clinic and ended up driving downtown every week for testing because we had a phlebotomist that we trusted, one who could handle Jackson's tiny veins with care and compassion. It was exhausting both physically and emotionally, but I would do it again in a heartbeat. The hope it gave us, the chance to improve Jackson's audiological outcomes and reduce potential complications, really made it all worth it. Today, Jackson is thriving. He has met all of his milestones, some right on the cusp, but still within range. He shows no signs of hearing loss or developmental delays beyond the typical toddler challenges, like the occasional ear infection that led to ear tubes. He attends preschool with his peers and keeps up every step of the way. And most days, you'd never know he was born with congenital CMV. He is truly the sweetest, funniest little guy. He has an infectious laugh and is always looking for ways to get others giggling, whether it's with a silly face, a goofy dance, or his perfectly timed toddler humor. He is full of determination and the most stubborn 3.5-year-old you'll ever meet. Potty treating him was no easy feat, it just happened. But the same stubbornness made him fiercely independent and tenacious, always eager to keep up with his big brother Colton, no matter how fast Colton runs or how high he climbs. When he's not chasing after his brother, you'll find Jackson fully immersed in his favorite things: monster trucks, skeletons, and all things silly and spooky. His excitement is contagious, whether it's racing trucks against the floor or proudly showing off his latest Duplo creation. To be honest, CCMV isn't something that's on our minds every day anymore, except when it comes to his regular audiology checkups, which he happens to have one this week. Otherwise, Jackson is just a happy, healthy, adventurous preschooler. But anytime I meet a pregnant mom or have the opportunity to share a story, CCMV is front and center. It's in those moments when I'm raising awareness, educating other parents, or advocating for better screening that I'm reminded why it's so important to share our experience. Jackson's story is a testament to the power of early diagnosis and how knowledge truly can make all the difference. Throughout this journey, we've leaned on incredible resources, including early intervention services, regular ophthalmology and audiology checkups, and support groups of other CCMV parents. Having this diagnosis early allowed us to be proactive, not reactive, a gift that came from that simple research swab. And knowledge. The knowledge is really the power in this instance. One of the hardest realizations for me was how little attention CCMV receives in prenatal care. I was shocked to learn how common it is, impacting 1 in 200 babies, yet it was never once mentioned by my OBs or midwives. They warned me not to eat the deli meat, change the cat litter, but the risks of a virus I could easily catch from my toddler were never discussed. As I mentioned earlier, my OB said Jackson wasn't a typical CCMV baby in my 6-week post-op appointment. I also ran into some issues later on with my sister-in-law's OB. She was pregnant soon after Jackson was born, and we were set to spend the holidays together in the same house. The exact message I saved from her was, "When you guys get a moment over the next few days, could you ask Jackson's doctor about his thoughts on risk exposure of CCMV to pregnant women currently?" I had to go to an appointment this week with a different doctor because mine was sick. And she was like, "Get a hotel and do not stay in the same house." But then my regular doctor was like, "You're fine. The risk is minimum." That right there goes to show the lack of information about CCMV to providers. It caused fear in my sister-in-law to see us, yet there is no additional risk than any other baby who may or may not have CCMV. This experience has made me a vocal advocate for CCMV education. I've shared our story with friends, family, and honestly, anyone who will listen, many of whom have never heard of it. The fact that CCMV can cause lifelong disabilities yet remains off the radar for so many expectant parents is heartbreaking. CCMV can be especially scary for a new mom navigating the roller coaster of postpartum hormones. You're already dealing with exhaustion, emotions, and the overwhelming responsibility of caring for a newborn. And then you're hit with a diagnosis that feels heavy and unfamiliar. It's easy to spiral into fear and guilt, but the more you know, the better off you'll be. Knowing about CCMV means that you can take action, staying on top of screenings, accessing early intervention services, and setting your child up for the best possible future. Of course, addressing CCMV in this vulnerable postpartum period is going to require compassion and care. This is where connecting parents to the right resources is crucial. Partnering with organizations like MDH and tapping into their support networks can make a world of difference. With the right information, guidance, and community, parents can move forward feeling empowered rather than overwhelmed. As someone who deeply believes in the value of research and that power is knowledge, I'm grateful we participated in the CCMV study. Without it, Jackson likely would have gone undiagnosed, and we would have missed the opportunity for early intervention and the chance to monitor him closely. I hope our story helps to raise awareness and encourages more conversations about CCMV, empowering parents to ask questions, advocate for themselves, and take simple steps to protect their babies. Because as someone once told me, not knowing the truth doesn't make it any less true. And in the case of CCMV, I fully and firmly believe that knowledge truly is power.
Thank you so much, Jess, for sharing, and we'll have you stick around and we'll do some Q&A at the end. And so after hearing Jess's story and learning about the basics of CMV and its potential impacts on infants and children, we hope that you are starting to kind of ask, well, what is my role in all of this? And how can I help address congenital CMV in the families and parents that I work with? And so we put together a few calls to action. And so the first call to action is to become aware. And just by attending this webinar and learning more, it's really the first step to becoming aware of congenital CMV. So this is a little graph that I like to use often. It illustrates the number of children disabled by the condition, and that is the orange dot on the graph. And then the blue bar is the percentage of women who've heard of the condition. And then all of the most common conditions that can happen during pregnancy are listed up the left-hand side. So as you can see at the very top is congenital CMV. It disables about 6,000 children each year, and only about 9% of women have ever heard of it. And we compare this to other conditions that are way less common in impacting children, and people's awareness about them is much higher. So we know that we have this gap between the number of people impacted and awareness, and that's what we are hoping you all as birth workers and doulas will be able to help us close this gap. So the second call to action is to learn more. We have lots of resources at MDH and others where you can learn more information about congenital CMV and be able to share that with families that you work with. One of the first and best places to go is to our webpage, and we have the full web address listed here on the slide. That web address gets you to our landing page, and that's the visual that's on the right-hand side of the slide. And so that's all of the information that we have on our webpage. So you can, if you're looking for information for yourself, can go under health professionals. If you're looking for information for families, we have a category for that, etc. The National CMV Foundation is also a great resource. They have educational downloads that can be used during visits with families. And just this past couple weeks ago, they actually even published a podcast episode that is specifically focused on doulas and how doulas can assist mothers and families in reducing CMV risks. And you can find that those resources through the website also listed on the slide. And then the last resource that's been a great activity for people to learn more about CMV is the book called Remedies for Sorrow, written by Megan Nix. So Megan is a mom to a daughter with congenital CMV, and Remedies for Sorrow is her memoir. We have used this book in study groups, and it has been used in book clubs at the national level as well. MDH has a study guide with reflection questions available. And if you want to use that in a book study and want to peek at our study guide and see if it worked, feel free to reach out, and we're very happy to share that study guide. The third call to action that we are hoping you will consider is to share information with families, with friends, with your clients. The messaging that we tend to focus on is that congenital CMV is common. It's detectable. Your baby will be screened for it with newborn screening. It can be serious, it's treatable, and it may be preventable. And on this handout that's available on our website, we have all of the tips that people can follow to help lower their risk of getting CMV. We know from research studies that counseling in those prenatal times can impact behavior, and providing people with this information and giving them those tips to lower their risk empowers them to choose what will work for them and their own pregnancy and in their own situation. And just from hearing Jess, really that was the information that she felt that she missed out on, was just knowing about CMV and been given those tips so that she could decide for herself what she wanted to do. This fact sheet, again, is available on our website, and we have it translated into 4 languages in addition to English. These are those specific CMV risk reduction tips, and they really focus on hygienic measures to decrease contact with the urine and saliva of young children. So kissing children on the forehead instead of the lips, avoiding putting things into the mouth that have just been in a child's mouth. I think Jess mentioned the pacifier, where the pacifier gets dropped and, mom will quick pop it in their mouth to clean it off before they hand it off to baby or their toddler. Not sharing utensils, food, drinks, or straws. Again, just limiting the potential for contact with the saliva of a young child, and hand washing, which is a very standard infection prevention tip, but especially after changing diapers, handling toys, or touching surfaces that might have been in contact with a young child's urine or saliva. I think we heard a little bit about the fear that can happen from others being around a baby with congenital CMV. Just mentioned that in her story as well. And it really is a very common question that we get here at MDH and have heard coming out of community as well. So the question is, I'm pregnant or attempting to become pregnant, and I know a child that was diagnosed with congenital CMV. Should I avoid being around this child so I can protect myself from a CMV infection? And the fact-based answer is that people do not need to avoid being around a child with congenital CMV. We talked about CMV being very common in all young children. And so any child with CMV is going to be shedding or excreting that virus in their bodily fluids. And a child known to have a CMV infection should not be treated any differently from other children. It is important that people who are pregnant or thinking about being pregnant protect themselves from CMV by using standard precautions and those risk reduction tips when they're around all young children, not just those that they know have a congenital or a CMV infection. And last call to action is to support impacted parents and families. As MDH continues screening babies through universal newborn screening, more and more babies are going to be identified. And so you will start to hear of either friends or family members or clients that you've had find out that their baby has congenital CMV. And again, the uncertainties of this diagnosis can be really stressful and anxiety producing for parents. And your support and information and pointing them towards these resources can really be helpful. So again, checking out our webpage, we have a booklet specifically for families and caregivers of children who have congenital CMV, and utilizing the National CMV Foundation are probably the 2 most best initial resources that you can provide. And last, I just wanted to share some information about how MDH is continuing to improve the awareness of congenital CMV in our communities in Minnesota. So as I mentioned earlier, increasing awareness was part of the directive that came through the Vivian Act legislation. And so we are actively trying to reach all communities with information. We currently have a campaign going on that's focused on digital and social and print media, trying to get the word out about CMV and helping people to find information about CMV from our website. And we are using multiple cultural communication tools to do that. And we are also relying heavily on our social media. These are some examples of our social media that we did last June for National CMV Awareness Month. So as we approach this June, hopefully you'll be noticing more information on your social media as well if the algorithm finds you, but we're trying to reach people through those social and digital means. And I think I'd like to just end our presentation with a quote here from one of our social media posts. And this was from one of our parents who had a child born with cytomegalovirus and was identified through newborn screening. And she said, "It was really scary in the beginning. And now that I know about CMV, I've told everyone I know about it." And we just ask for your partnership in increasing awareness about congenital CMV in our state. And now I think, are going to take some frequently asked questions.
Thank you so much, Gina and Jess. Could you go to the next slide, Jane? So my first question is for Jess. So you mentioned that Colton had been screened for CMV, and that you wouldn't have been screened for it for Jackson unless you had participated in that program, and you didn't hear anything about it from your OBGYN in between. So I'm curious about when would you have liked to have heard about CMV?
I think in that initial appointment, I believe it's like 10 weeks usually, where you meet with a nurse and they kind of go over like, okay, you're pregnant, you're, excited, and here are some of the risks. When they talk to you about, I have a cat, not emptying the litter box, or avoiding deli meat, certain medications that you're on that maybe you need to stop. Any of that. I think that's a really great time to have that conversation, especially if the risks are higher. So if you're in a childcare setting, if you're a teacher, if you're have a toddler or another child, I think that's really important to just at least share that information.
All right, Gina, we've had a few questions about breastfeeding and CMV. Should you still breastfeed if your baby has congenital CMV, or if you're breastfeeding and you contract CMV while you're breastfeeding? What are safety issues or concerns around those?
Right. Yep. So we did mention earlier that CMV can be in breast milk as well. For babies born with congenital CMV, they've already been exposed to that maternal strain of CMV during pregnancy. And so for most babies, breastfeeding following a diagnosis of congenital CMV is perfectly safe. People would always want to double check with their pediatrician or primary care provider, but for the vast majority of babies, there will be no concerns with being able to breastfeed after a congenital CMV diagnosis.
All right, so this is a question for both of you. First, we're talking about asymptomatic children versus symptomatic children. How many out of children who received the dried blood spot confirmatory diagnosis of congenital CMV, how many children, what's the rate of congenital CMV symptomatic children as it goes along? How many children become symptomatic as it goes along, or how many in general?
Yeah, the literature will say that over time, typically there's about 80 to 85% of kids that will exhibit some sort of symptom, and about asymptomatic. About 80 to 85% of kids will be asymptomatic, and that leaves about 15 to 20% of kids who will either have a symptom at birth or develop a symptom later. That time frame for kind of developing those symptoms, again, typically the research will say that signs or symptoms of congenital CMV will either appear in infancy or kind of that preschool time frame. And so that's usually when kids are monitored pretty frequently for those signs or symptoms. And maybe I'll turn it over to Jess so that you can kind of talk about that monitoring that Jackson has been going through, and maybe what your providers have talked to you about, kind of when would things typically show up for him if he was going to experience a sign or symptom of congenital CMV.
Yeah, and while Jackson, he would be considered asymptomatic, most likely, given kind of where we fell on the what we saw, what we didn't see. He was right on the cusp. But he was monitored until age 3 quarterly with hearing screenings. And then they do move to yearly after that. Because we have another child with hearing loss in our home, do every 6 months. But typically at that point, it's yearly. And I believe that will go until age 10, at least at our clinic. But it kind of varies. And what that'll look like. We're at the point where we're continuing, he has one Thursday, monitoring about quarterly-ish. The problem too, to keep in mind with the hearing screenings is winter is rough here with colds and head colds and ear infections. So we actually have kind of postponed because he would have symptoms of hearing loss, but he would have been congested. So it's hard to say, is that related to the CMV, or is that just a cold that, kids don't hear as well when their ears are clogged, essentially. So we've kind of spaced ours out where we're going like this week because it's warming up. He has a cold, but I'm hoping it'll be better by Thursday. So that's kind of that time frame and what we've been doing. So.
All right, I think that's it for our frequently asked questions. Thank you so very much, Gina and Jess, for joining with us today and for providing such great information. And to all of you for watching this webinar, it's really important that we spread this information about CMV to help support families and caregivers. Thank you.
Thank you.